So it's 11 o'clock. I suppose we should get started, but do we want to introduce the cute baby in the room?
Hi guys, you guys all know her, Alinity, but she's getting bigger.
Sure is. Yeah. Thank you. It's pretty yummy. Pretty yummy.
Oh goodness. It's just awesome. I guess we should probably try to stay on track as much as possible. Keith, do you have any announcements or anything?
I don't have anything specifically to start with. No.
Okay. Okay. I guess just a general reminder for everyone: our exam's coming up this Friday, 1 o'clock, Urey Lecture Hall. Since we'll all be in the same room, that should hopefully simplify things a little bit. 50 multiple choice questions. 30 of them will be for material that I've covered. Keith, I believe you have 15. Is that 15? And then 5 will be over the material that Kevin covered. Yep. And so that's essentially the distribution of the material. I've posted a study guide on Moodle after today's lecture. As soon as I've wrapped up with the lecture, I'll be updating that study guide to include the local anesthetics material, kind of in a more focused way. I just have kind of general notes on there right now for the local anesthetics, but I'll be updating that so it's a little bit more, again, focused and probably helpful for individuals. Hopefully the other sections that I've outlined, intro to CNS, alcohols, and things like that, have provided some structure and kind of direction in terms of the material that we'll be focused on for this exam. I'm looking directly at that study guide. As I'm writing my questions, again, I do like to have a really strong correlation between the things I tell you I'm going to emphasize on the exam and then the questions that are actually on it. Okay, so I suppose we should go ahead and get started here. Okay, sorry, just having to change things out here quickly. Okay, so like always, I'm going to be lecturing today. We'll be going over part 2 of local anesthetics. This has been uploaded to Moodle. So hopefully there's not a ton of overlap between yesterday's lecture and today. I'll be addressing some comments that I've received in the last 24 hours that have been super helpful. And like always, I'm leaving my chat window open. So if you have questions or concerns, as I'm going over material, please feel free to throw up any questions or comments into that chat. You can private message me if you're not necessarily a public share type of person. But if you, again, want the whole group to know, that's totally fine as well. Always feel free to unmic and ask questions. And so again, hopefully we can get everything accomplished that we set out to do today. So like I said, in the last 24 hours, I've had some really interesting conversations with students and some requests from students, and hopefully everybody will find the benefit from these future changes that are going to be made. And so some of the feedback that I've had is things like no repeater slides. So between different presentations, have no repeater slides given from one presentation to the next, try to make it one continuous stream. Apparently, I guess folks who take notes maybe find it a little confusing if you've got multiple copies of the same slide between multiple presentations. And so I'm going to try to not have any repeater slides and just have, one continuous presentation that occurs. And if I need to have some overlap between, let's say, a class, what I'll do is just I'll open up, let's say, part 2. Let's say we don't get all the way through part 2 during this class period. I'll open up part 2 at 1 o'clock. We'll finish that out, and then I'll open up part 3. So again, to just kind of eliminate any type of overlap with the presentation slides. There was a request that PDFs are uploaded, so I'll start saving them as PDFs and upload it as PDFs and PowerPoints. There won't be any student copies. The purpose of the student copy in the past was to not show you some of the clinical, so some of the concept check question answers. And so I'm going to be uploading those answers separately as a separate document, just so it doesn't, again, create any kind of confusion as to the multiple copies that are presented on Moodle. The presentations will be uploaded the night before in case you have any interest in looking over the material prior to attending class that day. That particular note might have to begin next Tuesday. And then class recordings will be posted the same day. Generally, they're uploaded to YouTube the same day. So if you follow my channel, usually they get uploaded the same day that we wrap. And I guess due to some technical issues, it's become far easier for me to change that turnaround time to very quickly. So now I'll be uploading those pretty much as soon as we wrap day of. So again, these were all suggestions that were made via students. I appreciate that dialogue. I think whatever is going to make your educational experience, especially in this climate, better, please make sure you're sharing those suggestions with me. So like I said, feel free to shoot me an email, have a conversation with me after class or what have you. And again, if you have any other suggestions, I'm again very open to them, and just make sure you're sharing them, and then we can integrate them into class. Okay, so in terms of the roadmap, kind of what we've covered and where we're going today. So in this presentation today, we're going to be focusing on local anesthetics part 2. We'll be talking about things like side effects, metabolism. We've hit upon metabolism a little bit yesterday, toxicity, a list of some local anesthetics that are used, some that are better for injections, some that are better for mucosal areas, region-specific types of blocks, and then we'll finish up talking about biological toxins, so toxins that occur naturally in the environment that have a very similar target site of action that we see with many of these local anesthetics. And so they can be, if they're, I guess, if you're exposed in the environment to them, can have negative side effects. Just a quick reminder, yesterday we covered chemistry, pharmacokinetics, and then finish up with mechanism of action. And hopefully you were able to either look over that presentation or remember. Again, most of the target of action that we're talking about here primarily are voltage-gated sodium channels, and not surprisingly, that's going to affect neural transmission. And we talked about how it affects neural transmission in yesterday's lecture. Okay, so this is a similar version of a slide that we saw yesterday, but what I did was I changed some of the chemistry and the way that the different compounds are essentially grouped. And so we are going to talk about, when we get to the slide on metabolism, talk about the differences in the metabolism between esters and amides. And so I just like this slide because it very clearly draws that distinction between those two groups. And so again, if we were to just define what a local anesthetic is, it's lost to a focal region. We'll talk about how that's achieved and other types of drugs that can be treated to kind of keep that focalness very focused. Again, consists of a lipophilic group and an intermediate chain connected to an ester and amide to an ionizable group. So again, you can see the groupings of these two different chemical groups here, your esters, cocaine, procaine, chloroprocaine, tetracaine as your esters, and your amides as lidocaine, budocaine, prilocaine, bucodocaine. We'll talk about how this is one of the more longer lasting local anesthetics a little bit later. So we'll slowly but surely hit upon many of these drugs in this particular presentation, describing essentially how they're used, some of their side effects, some of their metabolisms, and things like that. So again, this is just a nice general slide, just again, introducing the chemical properties and how these particular drugs are grouped. Okay, so in terms of local anesthetics, there are a few things that really can affect their ability to act. And so one of them is going to be pH. They're only slightly soluble as unprotonated amines. So because of that, they're generally marketed as hydrochlorides. And so what's interesting, I like this particular figure just because it kind of showed you what the pKa of some various drugs were and the percent of base form at the pH 7.4. Again, that's going to be physiological pH. We'll talk about onset of action a little bit later, comparing and contrasting some of those onsets of actions. But again, they're fairly weak bases in that form, and the values range typically from 8 to 9. Some of the original characterizations in terms of the effects of pH on local anesthetics was done by actually, injecting the anesthetic and then changing the pH of the extracellular environment, and then actually observing that they were able to essentially turn off the effectiveness of the local anesthetic on and off based off of pH. And so that was some of the original kind of research characterization. Obviously, this wasn't done in a human study. This was done in a research setting, but it was just kind of an interesting, I guess, conclusion to make that pH played such a critical role to the action of these particular drug classes. Something we'll talk about pretty extensively today is kind of the co-administration of local anesthetics with vasoconstrictors. And so vasoconstrictors are obviously going to decrease the amount of blood flow to an area. And so what it's going to do is it's going to essentially decrease the, the flow of a local anesthetic out of the region of interest. And so it's going to allow for a longer duration and contact with that particular region. So the point I have here is duration of action of local anesthetic equals time of contact with the nerve. So you're prolonging that time that it has contact with the nerve. In clinical practice, usually epinephrine is going to be used. And so again, I like this particular figure that I've included here just because it shows you some of the preparations that we'll be talking about today, but then also kind of how it's also co-administered or co-prepared with epinephrine. So again, it serves a couple different purposes. You're also decreasing toxicity of the local anesthetics because you're not losing them to the peripheral tissues and then having them affect them non-discriminatorily. Okay, so I guess kind of going off of that idea, there can be some negative side effects to the treatment of using a local anesthetic. And so you think about it blocking those voltage-gated sodium channels, but voltage-gated sodium channels exist in both excitatory and inhibitory synapses, right? So you can have things like convulsions occur if you have essentially a silencing of inhibitory synapses that it happens simultaneously. Again, inhibitory synapses are kind of like the brake pedal for the central nervous system. And so when you're playing that push and pull between excitatory and inhibitory, if by chance you silence a lot of inhibitory synapses simultaneously, it can lead to convulsions essentially because you've removed the brake pedal for the central nervous system. Not surprisingly, the treatment for this would be benzodiazepines for over excitation. You want to agonize the GABA A system. And so in that case, respiratory support might be needed. I again enjoy this figure just because it shows you as the local anesthetic concentration goes up, you can have these more severe side effects, things like coma, apnea, depression, and hypotension. And this also is a great figure because it transitions into our next point, talking about the effects on the cardiovascular system. And so not surprisingly, if you do disrupt neurotransmission or the pacemaker cells of the heart, that's going to cause arrhythmias. And so if you do have, let's say, a local anesthetic that hits those pacemaker cells, you can have ventricular fibrillation. And obviously that's going to be the spasming of the heart. You don't want that. Again, if you have direct cardiac depression, you can lead to things like cardiac arrest, hypotension, ischemia, and kind of this whole laundry list of extreme circumstances that might happen. So again, those would probably be like the two, again, main large effects that these local anesthetics can have if they're hitting either the central nervous system or the cardiovascular system. For a smooth muscle, they can depress contractions of the bowel, increase resting tone and decrease contractions of the human uterine muscle. What's interesting is that the neuromuscular junction, they can affect transmission, not surprisingly, again, because you're blocking those voltage-gated sodium channels. It's going to result in a loss of neurotransmission and that interaction between the peripheral nervous system and your skeletal muscle. Procaine, interestingly, can block the response of skeletal muscle to acetylcholine. So there's kind of an interesting interaction that happens there. In terms of hypersensitivity, there are individuals that do not respond well to local anesthetics. And so if you're one of those individuals, it's kind of hard to know that until you're exposed. There are people who go through kind of that skin prick test. When I was looking at hypersensitivity images, there were a bunch of individuals showing that skin prick test where you've got multiple types of anesthetics that are kind of, applied in a grid to see where you get that immune response. But it can lead to an immune response that appears as dermatitis or maybe an asthma attack. it's important to kind of distinguish those allergic reactions from the toxic side effects and the effects of the co-administered vasoconstrictors, because you need to delineate whether that reaction is because of the local anesthetic that you've exposed the individual to, or possibly that co-administration with the epinephrine. If they have some type of reaction to the epinephrine, that's also going to obviously lead to some type of hyperimmune response in that individual as well. I'm a few slides in, so I'm just going to pause really quick and ask and see if there are any questions about what we've covered so far about the chemistry, the pH, the vasoconstrictors, or the side effects.
So for these hypersensitivity, is there an immune response? So is it like an allergic reaction, or is it something else?
It's an allergic reaction, yes. It's a heightened. Yep. Did I see Keith?
Oh, just real quick, like just a note that the cardiovascular effects of these compounds are pretty substantial. And next semester in 444, we start off with Doug Coffin starts off with a big section on the heart. And some of these compounds will come forward again at that time because they're actually used as anti-arrhythmic agents. So just a little something for the back pocket there to think about the future a little bit and continuity between first and second semester topics. Thank you.
Yeah, I guess that's something to take out when we're talking about all of the drugs, the different effects on the cardiovascular. You're again getting kind of, I guess, a little bit of a taste of 444. So yesterday I think we briefly mentioned the metabolism of the local anesthetics. So the table that you see in your upper right-hand corner is again a nice laundry list of the different local anesthetics and kind of where they fall on the esters or amides sides of things. If you go back a few slides, you can actually see the chemical structures. The grouping will be very similar. The list of compounds that are here might be slightly different between these two, but I think it does give you kind of a good kind of overall sense of the different drugs that fall into the different groups. They're going to be metabolized differently, the ester type and the amide type, as to where they're metabolized and kind of and how they're metabolized. So the ester type is going to be converted into more water-soluble metabolites in plasma by butyrylcholinesterase. The examples that the text mentions are procaine and chloroprocaine. They're metabolized fairly quickly in less than a minute. The amide types, conversely, are metabolized in the liver by P450. Involving an N-dealkylation and subsequent hydrolysis. And so here you can see kind of a nice laundry list of those drugs that fall within that drug class and kind of their relative metabolic breakdown rates. In terms of prilocaine, the initial step is hydrolytic and forming olutolidine, and the metabolites can cause methylglobulinemia. And so And I kind of went a little crazy during this particular, when I was putting together this slideshow, because these hyperlinks that you have here are actually hyperlinks to, let's say you've never heard of this disease state. So if you click on it, and I think I'm gonna have to share my screen differently to be able to share this with you. If you are in fact interested in learning more about this particular disease state, you can kind of see here this, this PubMed description of this particular disease. And this is a genetic defect in the red blood cell metabolism of hemoglobin. And so this is, again, just kind of I guess, an extension upon what we have been talking about. Okay, so go back to the slideshow. So yeah, so anytime you see a hyperlink within this presentation, this is going to, it will send you somewhere related. And there's going to be a whole laundry list of drugs that we get to later that'll all kind of show you where that sends you to. Yes, so a question kind of popped up in the chat. Would an allergic reaction occur in the second exposure, correct, unless there was some type of cross-reactivity? So yes, in order for an immune response to be mounted, there would obviously have to be the first exposure that creates all of the the raised and antigen and antibody interactions. And so you would only see that heightened allergic reaction upon the second exposure, yes. And so So that, I guess, kind of brings up an interesting point that somebody might not be able to easily detect whether they have this this hypersensitivity to a particular local anesthetic until they have that second exposure. So they might have had it once and then think that they're fine. That second exposure, though, will change significantly. And it depends, I guess, on the antigenicity of the types of local anesthetics that you're using. When we get to talking about the different ones that are used, we'll talk about their one particular compound that's utilized because it has a different type of antigenicity than many of the other compounds. And so it's kind of used for folks who are hypersensitive. So because so many of these compounds do share common structures, they probably are detected by the body very similarly. And so we'll talk about that other kind of compound that it can be used in that instance. Okay, I guess metabolism, what else, what other point? Yeah, so extensive use of the amide-linked local anesthetics in patients with severe hepatic disease requires just caution. Again, just take note of that when you're treating with the amide type of local anesthetics. So again, it's just interesting to note the two different metabolic pathways that take place here, and then and also kind of the relative timelines for them. Okay, so when we're talking about toxicity, so again, we just kind of finished talking about hypersensitivity, but toxicity would be kind of a different topic entirely, where you've got this that's going to be related to the concentration of free drug and the binding of anesthetics to proteins and in the serum and the tissues to reduce toxicity. So one possible treatment strategy for toxicity is this treatment called intravenous lipid emulsion therapy. This seems to be kind of a hypothesized new treatment strategy for toxicity. So again, I went kind of crazy with the hyperlinks here. If you're interested in this particular treatment strategy, you can click on this hyperlink and it's going to send you to a PubMed article kind of outlining exactly what this strategy looks like. I've included this image here where you can see just an example of a free drug in the bloodstream and it's protonated and neutral form. And then in that neutral form, it can bind to those plasmid proteins. But in the case of the lipid emulsion therapy, it's going to form a bunch of micelles around that neutral free drug and kind of just soak it up and kind of remove it from the blood system. So the lipids simply provide a favorable milieu of micelles, which lipophilic drugs can partition, and then more complex pathways is not necessarily clear as to how that's going to play out. So it's just an interesting, again, possible treatment strategy for toxicity of local anesthetics. Factors that affect essentially this protein binding and the toxicity, age-related effects are obviously going to be important. It's important to recognize that individuals like neonates are going to have a relatively deficient in plasma proteins, and something that's going to ultimately alter the way this drug is seen in the bloodstream. Okay, so we have our first concept check. So a 33-year-old man is about to undergo a dental procedure. His dentist says that the local anesthetic he will be using contains epinephrine and asks if there is any history of heart condition or high blood pressure. So my first question for you is, why would the local anesthetic contain epinephrine? Hopefully we've hit that point home pretty hard. And then are there any concerns about the use of epinephrine with local anesthetics? So go ahead, just take a few minutes to review your notes if you want to do any searching online. And then once you have kind of come up with your answer, feel free to private message me what you've come up with. Okay, so I think I've gotten quite a few answers here from a variety of folks, and I think everybody's kind of hitting upon a lot of the key points that we've already kind of discussed so far. So in terms of um, why would the local anesthetic contain epinephrine? I think everybody kind of hit the idea of vasoconstriction kind of right on the head there. And so this is kind of, I think, a little bit more of a lengthy description of exactly why that would be. It performs essentially dual service by decreasing the rates of absorption, but it also localizes the anesthetic at the desired site, but allows the rate just right in the body to keep pace with the rate at which it is absorbed into the circulation. So ultimately, it's going to reduce systemic toxicity. And so in terms of this individual, again, it's worth kind of noting if there is any heart or high blood pressure within this individual's family history or within himself personally, just because it does work as a vasoconstrictor. And so because of this, there can be some issues with delayed wound healing, tissue edema, or necrosis. And we'll talk about some examples of when epinephrine is withheld from some preparations. This seems to affect the sympathomimic amines, increase the oxygen to the consumption of lungs. This with vasoconstriction leads to hypoxia and local tissue damage. The use of vasoconstrictors on local anesthetic preparations for anatopical regions with limited collateral circulation could produce irreversible hypoxic damage, tissue necrosis. Again, we'll talk about that a little bit later, and gangrene, therefore, contradicted. So it can be stressed that untoward cardiovascular effects of local anesthetics may result from inadvertent intravascular administration if epinephrine is also present. So again, this is kind of a prolonged, I think, description of the answer to what many of you gave, which is the correct answer. But like I said before, I'm only the version of the presentation that is posted to Moodle right now does not have this included in it, but I will be pulling out this particular slide and then posting it as its own individual set of information separate, but you will have access to the answers for this. Okay. Okay, so I think this is probably the part of the presentation that maybe folks get kind of not excited about, but this is where we're actually going to go into like the laundry list of drugs. We'll be talking about cocaine, lidocaine, bupivacaine, and then also talking specifically about local anesthetics that are suitable for injection, some that are suitable for mucous membranes, agents that we use for ophthalmic use, and then also finishing up talking about biological toxins. And so again, it's interesting to note that there are different local anesthetics that are appropriate based on where they're being applied and how they're being used. And we'll kind of talk about the pluses and minuses of each one of those. Okay, so we're going to start with kind of the grandfather of local anesthetics, cocaine. I think the question yesterday that was posed maybe at the end of class was the AIN kind of suffix that follows all of the local anesthetics, kind of like what is the origin? And I think many of the canes or the local anesthetics that kind of come from this family of compounds are derived or come from that idea of cocaine. I believe the nomenclature of cocaine came from the plant from which it was originally characterized. I feel like this is a place where Keith can kind of come in and talk a little bit about the history of cocaine, just because it's fairly abbreviated in our textbook, but I know that there is such a wide, just a long history of this particular compound being used. I believe it was originally found in, the plant that grows cocaine. The leaves were chewed upon by the Incans. Eventually the Spanish came over and were able to kind of figure out how to purify out that compound. I think I read that they took it back to Europe and they actually had a hard time. It was almost like a hard sell just because tobacco had already hit in Europe. And I think there was a lot of that gained popularity a little bit more strongly and quickly. And then in terms of like over the years, cocaine did kind of find its place, was used medicinally for many, many years, but because of its properties as a norepinephrine transport blocker, it obviously increases the amount of dopamine in your system. And again, dopamine is going to start to create those highly addictive pathways. And so there's a very high addictive, capacity for cocaine. I included kind of this image that you see here of these cocaine tooth drops. Again, this is in the 1880s that cocaine was being given medicinally, and you can even look into the early 1900s. I wanted to Google that idea of like, did Coca-Cola originally have cocaine in it? And the answer to that is yes. That is not just a myth. The original Coca-Cola did in fact have cocaine in it. Obviously it was, between the cocaine and the caffeine was seen as this great stimulatory drink that could be used. But yeah, I'm going to pause there because I want to see if Keith maybe has anything to add to the history of cocaine.
Not much really. That's really great what you had there, Katie. Just in terms of the popularization of it, Sigmund Freud had a role in that, if I remember correctly. And one, I noticed at the bottom of your slide, you've got the fact that it's a Schedule II drug, and that's a point that people often miss. They'll just immediately assume that cocaine is Schedule I because of its notoriety in our society, but in fact it's Schedule II. And in a slightly different note, same thing for methamphetamine. People immediately think that it's Schedule I, and it's not. It's Schedule II also. I'll stop with that.
Yeah, I mean, it's interesting to note. I think when we think of cocaine, we often, I think, primarily focus on that first action as a norepinephrine transport blocker and its role in its interaction with dopamine. But it does act as an anesthetic and a vasoconstrictor, and so to that degree, it's still used sometimes clinically, ultimately as an anesthesia, and to also shrink the mucosa. That allows, in some instances, in surgical instances, a better view of the area. In terms of the way that it's prepared, you can see here that it's prepared in a 1%, 4%, or a 10% solution. And we'll talk, I think, about cocaine a little bit more later on. But again, it's obviously not probably the first local anesthetic that folks go to, again, just because of the high addictive component to it, but was kind of that compound that started things off, and we'll see kind of how things have progressed since then. So probably the one that's far more clinically used now is lidocaine. So we can see that it provides faster, more intense, longer lasting, and more extensive anesthetic effects than procaine. It's a nice alternative to those who are sensitive to esters. Again, when we talked about hypersensitivity, it's always important to kind of have options if someone is hypersensitive to one group or the other. Used prior to venipuncture, skin grafting, harvesting, infiltration to analgesics into genitalia. And lidocaine, a combination of lidocaine and tetracaine is actually used for chemical peels that you might associate with more cosmetic types of surgeries. The ADME for lidocaine, it's rapidly absorbed. Epinephrine is obviously going to decrease that rate of absorption and can be used in a variety of ways. Here you can see topically, ophthalmically, mucosally, and transdermally. It is metabolized by the SIPs, and you can see kind of some of the metabolites here. And then finally is excreted in the urine as this final metabolite that you see. If it has been administered, over-administered, you can see some side effects here, drowsiness, tinnitus. But if administered to a high enough dose, it can result in things like seizures, coma. So when we were looking at some of those central nervous system and cardiovascular effects and kind of the more severe examples of that, you can see here that lidocaine definitely falls within that category of reaching that level of depression, both in the CNS and the respiratory system. So I guess, so somebody popped up in the chat and asked, does it have much oral absorption? It does have oral absorption. I'm guessing that oral absorption is kind of a relative term, but that's an interesting question. And maybe I will go ahead and look into that, and then we can kind of come back with maybe like a relative comparison of lidocaine orally versus maybe transdermally during our next session. So lidocaine and cocaine are suitable for mucosal absorption. So these are, again, you can see that the reason that they're not categorized kind of in those subcategories for like that were given, I guess, into that previous slide. Let me go back. So here we can see there are kind of drugs that are categorized as being suitable for injection or suitable for membranes and skin. These kind of hit multiple of these categories, and so that's kind of why they're being separately presented, because they can be applied either mucosally or injection or transdermally. So they have multiple routes in which they can be administered. So they're just not falling into one or the other. But we'll talk about how some of those other drugs might be more suitable than these ones that are, I don't want to say broad spectrum because that's kind of a misnomer, but can be administered through multiple routes. Oh, so does Coke have a high oral absorption? I imagine that there is some oral absorption of it. Yes, it's still able to cross the barriers to be taken up and still have the effects that you would expect. Sorry, coming back to lidocaine here. Oh, and again, we talk about lidocaine. That's kind of, I don't want to say the bread and butter local anesthetic, but it is it's a wide range, has a wide application as an anesthetic and can be used as an antiarrhythmic agent. And I think Keith kind of alluded to the fact that this might be one of the drugs that we talk about while we're discussing the cardiovascular system in spring semester. Bupivacaine is, again, has a wide range of uses. And again, that's why cocaine, lidocaine, and bupivacaine are kind of being presented separately. The difference with this particular drug is that it's much longer duration of action versus some of the other ones. And so if you need some type of prolonged local anesthetic, this is actually the drug of choice. It can be applied via indwelling catheters and via continuous infusions. It's primarily metabolized by the CYP3A4. It is worth noting, though, that it is more cardiotoxic than we see with lidocaine. And the block is kind of more cumulative with a single injection, with multiple injections than you would otherwise anticipate. But it is kind of difficult to treat these cardiotoxic effects that occur. I included this table down here because I think it does a nice job of comparing, contrasting, if you're treating with just lidocaine or bupivacaine or the combination of both, the mean time of onset as well as the mean duration of action. And so you can see with the 1% lidocaine solution, you've got a mean duration of roughly 3.17 hours at a 1% solution. And then the bupivacaine has a mean duration of almost 9.5 hours. So it's a pretty considerable different duration between the two. Sorry, I saw that click. I got click happy. I saw that come up and I immediately clicked on it, and that's probably not the best thing. Okay, so our next concept check question. So a 30-year-old woman presents to the office for a treatment of an ingrown toenail. For the past 3 weeks, she has progressively worsened redness, swelling, and pain from the area around the right toenail. On examination, you find distal media corner of the right great toenail is ingrowing. The skin is in the medial border. There's a visible purulent drainage as well. You place her on 1 week course of oral sulflexin and have her return to the office. On the follow-up, the redness is markedly improved, but there's no further drainage. You surgically correct the ingrown toenail after achieving local anesthesia with 2% lidocaine injected to infiltrate the digital nerves. And we'll talk about infiltrate injections here in a bit. So what is the mechanism of action of lidocaine as an anesthetic agent? And why does the treatment of the infection increase the effectiveness of local anesthetic? So I'm going to pause here for a second. The second question, I don't think we've really hit upon as much. So it'll be interesting to kind of see what you come up with your online search. Okay, so it seems like most of you have figured out the first part of this question. I think it's something that we've hit upon multiple times. The mechanism of action for lidocaine um, is going to be those voltage gated sodium channels. But the second question, I haven't had as many individuals give well an answer to. But would anyone care to just verbally describe a hypothesis?
My guess
Sorry, Rebecca, go ahead.
My guess was that like when you get an infection, your immune system is going to fight it like with the swelling and stuff, which would loosen like the junctions between cells to allow your immune system to infiltrate. And so that would allow the like local anesthetic to leak into like the other places, and that would shorten the duration of effect.
Okay, I think that's a great hypothesis. There's another something that we've discussed prior also that's going to play a role. So I think that's like that could be one component. Something else we've discussed. I've. Does anybody else have any suggestions?
So I said that the pH is different with an infection, so then you have more charged anesthetic on the outside of the cell that doesn't get in.
Yeah, exactly. So I guess that's probably more that falls in line kind of with the idea that the infection of the inflammation lowers the pH, reducing the diffusion agent into the nerve and thus reducing its effectiveness. So exactly, Sydney. So I think the loosening of the gap junctions definitely it's going to affect the way that drug diffuses. But in terms of actually gaining access to the cells, I think this alteration in pH is going to kind of have maybe a more direct effect at those sodium channels. And again, kind of goes back to something that we talked about at the beginning of class today. Okay, well, we ultimately have about 2 minutes left before we take a break here. So I'm just going to pause really quick and see if anybody has any questions. Maddie, did you find a PubMed article about this specifically?
Sorry, I was sitting very far away. I have this on a projector in one of the classrooms in Skaggs. But I found an article about how infection increases the sodium concentration in the skin. So that's what I was thinking.
Oh, okay. Nice. Yeah. And what I really appreciate about having the chat window up here too is that somebody even earlier used it to post a link to an article. So as we're discussing things in class, if you do like get online and you find something that's valuable, that's going to supplement the discussion that we're having, throw it up in the chat for everyone to see, because I think it can be really advantageous. So even now, Eddie, the article you found, if you want to share it with everybody, that's great. Just because I think it gives you that opportunity to go and look at some of the primary literature, primary research that's kind of supplementing some of the conversations we're having in the class. Okay, I guess. So the local will be more concentrated at the site. So you wouldn't have as much spread, but you also, I guess the big takeaway here is that because of the differences in pH, the drug wouldn't be able to penetrate the cells. So it's not, so I guess the bigger kind of part of the answer of this is that the penetration to the cells is going to be altered, if that makes sense. Okay. If anyone seems like I'm talking out so what I need to do is start just reading the questions out loud and then giving the answers to kind of put it in context that makes sense to everybody, because sometimes I just read the questions and start giving answers. Okay, it's officially 11:50. I'm going to let everybody go. If anybody has any questions or has anything that they'd like to add or sit back and have a conversation, I'm happy to do that after this class. I'll see everyone at 1 o'clock. Again, we'll continue and we'll finish part 2. I'm going to be posting an updated part 3, a few more slides, and then we'll finish out local anesthetics today. And that will be where the material for the exam finishes, is with this series of presentations. And then I'll be updating the review sheet on Moodle at the end of today and posting all of the videos. And so hopefully you'll be feeling prepared for the exam come Friday. Okay, everybody have a wonderful lunch, and I look forward to seeing you soon.